Okay, our next speaker is Dr. Arnold Sansevere. Dr. Sansevere is at the Children's National Hospital in DC and has been a speaker at our event for like the last, 6 or 7 years, I think. He's comes every year. We get a great talk on newly diagnosed kids and understanding that new diagnosis. Feel free to put your questions in the chat box, and I will make sure that the doctor gets to them at the end of the talk. Should be very informative and a great slide presentation as well. Okay, Doc, you can take it away.
Okay. Can everybody see my slides? Is this working okay?
Yeah, it looks great.
All right, great. All right, so again, I'm Arnold Sansevere, and first I just wanted to say thank you to the organizers. This is by far my favorite talk every year, and I just think it's such a wonderful resource for patients and families. So I want to thank them again for organizing it. And as Brad mentioned, I will be talking about what sort of to do and what the thought process is when kids are newly diagnosed with epilepsy. And I have a few slides here, but this is really just to sort of set the stage for questions, because I think that's the most important part about this session. So we'll get started. No disclosures or conflicts of interest. So just to give everybody a sense of what we're going to talk about, I think if you're going to take one thing from this presentation, it should be that you've gained a better understanding of what your doctor is thinking about when a kid has a seizure. I think that's super important. But we'll focus on other things, such as when do we treat a seizure? Does the seizure type matter? Does the duration matter? I want to spend some time on just going through basic first aid, because that's super important whenever a child has a seizure. And then I do want to talk a little bit about some rescue medication options. And then towards the end, we're going to talk about some of the comorbidities that come along with having seizures and epilepsy. And I find that oftentimes those comorbidities are as severe, if not worse, than having a diagnosis of epilepsy. So we're going to focus on that too. All right, so as I mentioned, super important to understand what your doctor is thinking. So I just wanted to give you guys a sense of what we're thinking about. So the first thing that we think about was the event a seizure, right? Because believe it or not, there's a lot of mimics out there. So you want to be very certain as a physician that a child has presented with a seizure. Now, oftentimes it's very clear, but there are many situations in which it's really not. So once we've decided that yes, the event was a seizure, we ask ourselves, what type of seizure was it? Was it a generalized seizure in which both sides of the body tend to be involved? Was it a focal seizure? And just to give you a sense of what those different seizure types look like. So generalized seizures can present themselves like the standard seizure people think about when kids have stiffening and jerking. But other generalized seizure types are things like absent seizures, where kids stare off into space, maybe their eyelids flicker, they may be disoriented for a second or two. Some children have a seizure type called a myoclonic seizure, where it seems like this big bolt of lightning goes through the child's body. And then focal seizures can just affect one side of the body, but they can also present with just periods of confusion that then lead to this sort of period of fatigue or tiredness. So those are just some very general examples of what seizures can look like if they're generalized or focal. The challenging thing is that sometimes focal seizures can turn into generalized seizures. So that's why you'll find that we ask a lot of detailed questions about the child's state before they have the seizure. We'll try to tease that out. One test that we really rely upon is the EEG. This is just the brainwave test. That can help us a lot to decide, number one, if the event was a seizure, but number two, what type. And then we ask ourselves, well, what was the cause? And there are many different causes of seizures out there. One is a simple brain abnormality. This could be something that happened at birth, or certain abnormalities in which the cells don't migrate properly, and over time we find that kids have what are referred to as cortical dysplasias, where these little lumps of cells that cause seizures. We rely heavily on the brain MRI, which is just a picture of the brain to help us decide if there was a brain abnormality or injury. We're learning a lot about genetic causes of seizures and epilepsy. However, I do stress that this doesn't necessarily mean that it came from mom or dad. It is oftentimes the case where kids develop genetic causes of epilepsy without a clear family history. And then, unfortunately, we are then sort of left with this third bucket here, where there are cases in which kids come in with seizures and epilepsy, and we just don't have a cause for it. And that can be really frustrating for patients, families, and physicians. We then ask ourselves, well, what is the best treatment? The thing that we first start with is medication tends to be the safest in many cases. But if those aren't effective, we think about diet therapy, diets such as the ketogenic diet, low glycemic index diet. These are diets that we oftentimes use to try to decrease seizures. And then in some cases, we can provide brain surgeries. And keep in mind that a brain surgery does not necessarily mean that we go into the brain and take part of it out. There are other types of surgeries, such as a corpus callosotomy. Some of you may have heard about that. Other options are things like the vagal nerve stimulator. As time goes on, we're doing more and more procedures that involve stimulators that are placed on the brain to detect when there's abnormal activity and then suppress it. And then I think it's really important to sort of discuss our rescue plan. And the most important part of that rescue plan is being well versed in seizure first aid. Because oftentimes seizures don't necessarily lead to the point where we're going to intervene with medications. Unfortunately, sometimes they do, but for the most part, seizure first aid tends to be enough. But we will talk a little bit about rescue medication options, because it's always important to have that on hand as well. Briefly, we'll go through some EEG basics. So what do we look for? Whenever a kid has an EEG, we should see these very nice waves. And you can see that depicted here in this first picture here. We also look for abnormal waves called spike waves and sharp waves, and they just look spikier and sharper than these background normal waves. And it's important for us to know where those abnormal waves are coming from. Are they coming from one side of the brain where we might suspect a focal form of epilepsy, or both sides of the brain in which we might expect that kids have generalized seizures? One common question that I get about EEG is, all right, are these spikes and sharp wave seizures? The answer to that is no. I think of them as sort of these sparks before you have a seizure. And the other thing that parents oftentimes ask is, do spikes need to go completely away for seizures to be controlled? And the answer for that is no as well. And it's still okay to have a certain number of spikes as long as seizures are controlled. And again, there are caveats to each situation, but generally speaking, it is oftentimes the case where kids can still have spikes, and as long as their seizures are controlled, we still feel pretty good about it. The seizure type matter for emergency treatment. Keep in mind that not all seizures are the same. Many kids have very short and brief seizures. In those situations, you may not want to be as aggressive with rescue medications. Some kids have focal seizures where you can still have some degree of retained consciousness. Some kids have daily baseline seizures that vary in frequency. So every kid is a little bit different. To give you a sense of the types of seizures that we worry most about, we do worry most about those big generalized tonic-clonic seizures. And we worry more about them if they're approaching that 5-minute mark. Because what we do know is that if a seizure is going to last 5 minutes, those kids have a higher chance of having seizures lasting much longer. So a lot of times doctors, or I'm sure many of you already experienced this, doctors say, all right, we're going to give that rescue medication at 5 minutes. And this is the reason why. Because we worry that if it's going to last 5 minutes, it's going to last much longer. So as I mentioned, basic seizure first aid is super important. The most important principle is to keep your child safe. If they're in a situation where there are things around them that can harm them, you want to get them away from that environment. So I usually recommend just lowering your son or daughter to the floor. Clear any harmful objects. These can be sharp objects, maybe just a lot of things such as a lot of furniture in the area that if a child is having a seizure, they can harm themselves from them. Do not restrain your son or daughter. That's very important. Do the best you can to try to turn them on your side so they don't aspirate, because we worry if a kid is going to aspirate when they have a seizure, they're at high risk for things like infections. Support the head. It's really important to get a sense of the timing. Do not put objects in the mouth. This is something that people would do routinely years and years and years ago. We don't recommend that. And whenever a child is having a seizure, if you've been given a rescue medication, it's important to know where it is, go to the cabinet, find the rescue medication. If you feel like that seizure is not going to stop before that 5-minute mark, it's a good idea to start prepare the medication. And then once you've been concerned to the point where it's going to last more than 5 minutes, that's when you administer the medication. The Epilepsy Foundation, so just epilepsy.com, has a lot of really nice resources. This is one that sort of talks a little bit more about Seizure First Aid. I also find that it's important to make sure that other people are educated with regards to what to do if they're in the presence of a kid who has a seizure. Because unfortunately, I don't think as a society we do a good job about teaching people enough about seizures and epilepsy. So I think it's important to try to do that, especially when your loved one has epilepsy. And this is just details of that website that I like. But like I said, it's just epilepsy.com. After the seizure, you want to assess breathing. I always recommend the parents are trained in basics of CPR. It's really important to reassure the child, because as you can imagine, if you just had a seizure as a kid, you must be frightened and just so scared when you're kind of coming out of it. So it's important just to do the best you can to reassure them, tell them that it's over, tell them that they're in a safe place. Very important. And then, of course, to let your son or daughter or grandchild know exactly what happened. Don't give any water or pills right away. These are also important points. And as I mentioned, it is oftentimes the case, not always, but oftentimes the case where basic seizure first aid is the only thing that you'll need to intervene. So it's really important just to understand the basics of it. If you look further on that website, there are a lot of actually very helpful apps that you can use. I like this one. It's just called Seizure First Aid. Once you open the app, it kind of talks you through the process. As part of the app, it's a timer, and it actually alerts you when you're getting to that 5-minute mark. There are definitely other ones that are out there, but this is one that I like. And then, what if seizure first aid is not enough? That's when we start thinking about the rescue medications. And the good thing is that this has changed over time, meaning that, 10 years ago, we really just had rectal formulations, but now we have nasal formulations, some buccal formulations. Sometimes we can use disintegrating tabs. So the tried and true formulation is Diastat, which is just diazepam. This can be given rectally. Sedation tends to be the most common side effect. We oftentimes worry about respiratory depression with these medications, but fortunately, this is extremely rare. It can take a little bit of time to work. Some people have said up to 15 minutes. I must say, from my experience, it tends to work before then. But there's nice instructions in the handout to sort of walk you through the process of how to administer it. There are now nasal formulations out there. So Nasolam is essentially intranasal midazolam. Kids greater than 12. Valtoco is intranasal diazepam for kids greater than 6. Side effects are the same, but it's just nice because it's an easier way to give the medication, as you can imagine. And I like this, so you are saying noses can be used for more than just spelling. Really? Medications can go up there too? And fortunately, the answer is yes, especially in the setting of seizures. So when to call 911, I find that this is not always a straightforward answer. To be honest with you, it's important to discuss this with your doctor. I think some basic principles of when to call 911 is if a seizure has lasted more than 5 minutes, I always get concerned about those. If it's a first seizure and a kid who does not have a history of seizures, then of course you should call. If you find that seizures are happening one after the other, and that's not typical, it's another reason to call 911. If there's any problem with breathing, of course, or you're concerned that your child may have choked or aspirated, that's another reason. If the seizure is to occur in water, of course, that would be another reason to call 911. If you're concerned for any injury, if there's bluish discoloration after the seizure that doesn't improve, if after the seizure they're just not back to their normal baseline compared to prior events, and then of course if any person asks for medical help, that would be an indication to call 911. And then just some seizure precautions. I try to be very conservative when it comes to seizure precautions, but also keeping in mind that, unfortunately, we can't put our kids in bubbles after they've had a seizure. So in that setting, I just suggest that everyone's just careful. A lot of these things are things that you're doing anyway in kids with or without seizures. So things like if the kid is going to ride a bike, they should have protective gear. We don't suggest riding a bicycle or skateboarding on a street that has a lot of traffic. Water is a big thing. I think kids always need to be supervised around water, obviously, especially if they have seizures or epilepsy. One thing that some families forget to do, especially in the teenage kids, it's important to make sure that if they're taking a shower, the bathroom door should be unlocked, just in case something were to happen, you can get in there right away. Protective gear for sports, avoid any unsupervised heat sources. And then with regards to prevention, one thing that we do have some control over is sleep. We find that lack of sleep can bring seizures out. So the opposite is true, where if you get good rest, that may help prevent seizures. Make sure you're taking your medications and keeping a diary so you can identify triggers that you can easily avoid. And then finally, just one quick slide to chat a little bit about a lot of the comorbid conditions. So, in reality, epilepsy is really just the tip of that iceberg. A lot of kids that have epilepsy are at higher risk for things like attention deficit, learning disabilities, even things like depression, anxiety, OCD. Many kids have comorbid tic disorders. So because of this, I have a very low threshold to do a psychological evaluation, because I think it's important to get at to make the diagnoses of some of these comorbid conditions early. Because I find that if you start really working on them early, it becomes less of a problem as time goes on. Neuropsychological evaluations can be helpful too. Whenever a child has a diagnosis of epilepsy, they are allowed to have a 504 plan, which just allows the schools to put supports in place without going through the whole IEP process. But there are situations in which I will recommend an IEP because oftentimes it's the case that once an evaluation is done, they can offer even more support. Yeah, so these are just some very basic principles that I wanted to talk to everybody about, and the purpose is just to sort of, open up discussion on some of the things we've learned about and answer any questions that you might have. Thank you so much for your attention, and we'll take questions.
Thanks, Doc. If anybody has questions, you can please put them in the chat message box. Do you see that question in the text box, Doc? Somebody is asking, is vomiting prior to a seizure normal, or is the seizure brought on by vomiting?
So that's a great question. So it's a little bit of both. So there definitely are seizure disorders that, number one, especially in younger kids, vomiting can actually be the seizure. A lot of people don't always think about that. That being said, the most common cause of vomiting is going to be a GI illness. It is oftentimes the case that kids can vomit before because they have some sensation. So sometimes kids can get this rising sensation in their stomach as kind of this warning that a kid is going to have a seizure. So in that situation, it may be seen before. I must say that a lot of kids tend to have vomiting after they've had a seizure. So I think those are the two scenarios in which vomiting can be pretty common. All right, so we have another question here. So, and I'll read it aloud. So actually, I had the same question about migraines. I'm having a hard time figuring out which is coming from which, right? My youngest gets migraines often, always after a seizure. I don't always see a seizure before the migraine, but she does have absence seizures and atonic. Yes, so it is unfortunately oftentimes the case where kids have both migraines and seizures. I will say that for the most part, if kids, it sort of depends on when the migraine starts. I must say that I would, for the most part, what I've seen is that kids that have migraines, tend to have that migraine first, and that can then potentially precipitate something. Because keep in mind, any stress in the body can theoretically bring out a seizure. But the opposite is true for kids who are presenting with their seizure. That can then trigger a migraine. So again, I think it's more if the migraine comes first, for me, that tends to be more of a migraine phenomena starting. But if it comes afterwards, then in that situation, it's just the seizure that has triggered the migraine. But it can be oftentimes very hard to tease out. I took care of one kid a few years ago that had this exact same problem. She developed this migraine, and every single time she would develop a seizure. But my sense was that it was that migraine that was just lowering her threshold that would then lead to the seizure. But again, not always easy to tease out. I will say, however, there definitely are some seizure medications that are good for both migraines and seizures, and I do tend to try to use those in kids who have both. So that's something that I would definitely talk to your doctor about if you haven't already.
Doc, I have a question for you. How are you managing with so many of your patients unable to come into the clinic during COVID? And I'm sure you're treating by telemedicine, but let's hear how that's going for you.
Yeah, so a couple thoughts on that. So, surprisingly to me, the majority of my families love telemedicine. Now, little bit of a caveat to that. My families who are established and who I know well, those are the ones that just love telemedicine because it's one less trip to the hospital, right? You don't have to pay for parking. Oftentimes, you can still go to work and just zoom into the visit. So from that standpoint, they've loved it. I'm not so crazy about a first-time evaluation for epilepsy or any neurologic disorder, just because I really do like to do a full neurologic examination and just meet the family in person. But like I said, for the most part, the families that I've been taking care of, just they really love it, and I'm actually very hopeful that some form of it stays with us because I just think it's convenient in many situations where things are kind of going well. Maybe there was a breakthrough seizure or two, and I just need to make some medication adjustments. So from that standpoint, it's been really good.
Yeah, it's funny that it's gone full circle because I can recall back to 2013 and 2014 when we first started the expo, and patients were coming to the expo and meeting doctors like yourself that traveled 3,000 miles to speak, and they want to know how can you become their doctor when they live in California. It
Yep.
became a little rough, and there was no telemedicine. Insurance companies laughed at us,
Yep.
and it was just, and now it's a given. It's a
Yeah. I know. No, I mean, it's kind of a shame that we had to go through a global pandemic for people to realize that it was useful, But like I said, I really hope it stays to some degree for sure.
I agree. And then you've got another question here. Any suggestions on how to explain to a child that has a speech delay and a mild cognitive delay that they're having or have had a seizure? How do you explain that?
Yeah, the first thing that's really important is that I try to make it very clear to the kids that they're not alone. Seizures are much more common than people think, and I will guarantee that there are at least a handful of kids in every school that have seizures and epilepsy, and either they're just not talking about it, or many different reasons for why kids obviously wouldn't want to talk about it, right? Because I mean, they probably feel badly about it, and it sort of like makes them feel generally different from other kids. So that's the first thing. I just try to explain to them that they're not different. And then I'm very open. I simply say that because your brain is putting you at risk for seizures, you're at risk for other things, like maybe you're having a little bit of a hard time with your speech. But then I tell them it's okay, and I reiterate the plan, right? Because in those situations, I'm a big advocate for things like, as I mentioned, there's like testing, getting appropriate support. And that's the way that I approach it. It's important, I think, to be as transparent as you possibly can with seizures. And that's how I approach it. And with regards to telling them what a seizure is, I just simply tell them that, their brain sometimes fires when it's not supposed to. And that's my typical approach.
And also to add to your answer for Ariana, there are a few books out there written for kids, and great artwork as well. I'm drawing a blank on my brain right now after 2 days of Expo, but Ariana, if you email Brad at epilepsyawarenessday.org, I will send you the link to those books. I've used them several times, given them to patients. They're amazing. Does anybody have any other questions for Dr. Sansevere? Looks like we have all the questions answered, Doc. You got done quick.
All right.
I'll be showing this talk over again on YouTube, so we'll have it up for eternity, like all your other talks.
That's great.
And I will hope to be emailing you if anybody has questions specific to you. I will forward them over, and we'll get them addressed.
That sounds great.
Thanks, Doctor. I appreciate it as always, and I hope we talk before next year. But we'll see you at Disneyland in 2022.
Can't wait. Very excited.
Thank you, sir.
Thank you.
Take care.
Bye-bye.
And we will be back at 12 o'clock with Monica Jones, who will be giving a talk on IEPs for transition in school. Very important talk. Monica is definitely an expert on this. So if you have a child who's not getting all the accommodations and services that they need at school, this will be a great talk for you guys.